Welcome to today's Medicare 360 show. I'm your host, Jennifer Lee, and let's get started. Today, I wanted to cover the breakdown of the prior authorization changes coming to original Medicare. That's fee for service, effective January 1st, 2026, under the WISER, I don't know if it's WISE ER pilot model established by the Center of Medicare Services. So let's begin. And just keep in mind, this is for original Medicare. If you do have a Medicare Advantage plan, this has nothing to do with that. This is based on original Medicare. If you have that red, white, and blue card, if you're using that, and also like a Medicare supplement, like a Plan F, G, or N. Want information on that, let us know. But today we are going to cover first the background and the legislative context on it. So part of the broader reforms aiming to streamline prior authorization across all the payers, which is Medicaid, in California it's Medi-Cal, Medicare Advantage, ACA plans codified in CMS's interoperability and prior authorization final rule, January 2024. It mandates electronic systems, turnaround times, 72 hours, the ones that are expedited in a 7-day standard rule, denial reasons, and public reporting by 2026. So the WISER, that stands for Wasteful and Inappropriate Service Reduction Model, is a 6-state pilot targeting traditional low requirement original Medicare. It's overseen by CMS, CMMI, which can expand successful pilots without new congressional approval. Hey, this pilot was authorized in the Inflation Reduction Act. The biggest thing for that was in 2025, covered drugs were going to be capped at 2,000. There was some disruption about that. So now for 2026, this is probably the biggest disruptor of actually the 6-state pilot program. So other legislative authorities aiming to test AI-assisted workflows in fee-for-service Medicare. So why this is really important is because if you are an original Medicare, there are no prior authorizations till now with the 6-state pilot program. Meaning if it's covered on original Medicare, you don't need to get any approvals or authorizations like you do in a Medicare Advantage plan. So this might change people's options, opinions, or what plan to sway to when getting onto Medicare. So let's talk about the pilot scope, when, where, and what. The start date will be January 1st, 2026. It will last through December 31st, 2031. So technically a 5-year pilot program. The states will include New Jersey, Ohio, Oklahoma, Texas, Arizona, and Washington. So the services targeted, there are 17 categories, and examples include, electrical nerve stimulators, various types, sacral, phrenic, deep brain, vagus, hypoglossal, epidural steroid injections, cervical fusion, knee arthroscopy, or debridement. So I would say a lot of seniors do maybe the knee stuff just because that's one of the things that I've seen more often as ailments. Skin tissue substitutes for chronic wounds, incontinent devices, impotence treatment, spinal stenosis decompression. So I would say like the skin and tissue substitutes for chronic wounds. I know on original Medicare, it's very easy because there's no approvals for that. So I have seen that and so forth. So how the prior authorization process will work. Providers in pilot states must either request pre-service prior authorizations or proceed with care and later undergo pre-payment medical review. I mean, I would really go for the request for pre-service or pre-authorization. No one wants to pay something that's not going to get approved. And since it is a pilot, you need to be careful with that and talk to your doctor. Technology. An AI assisted system will help validate documentation and flag requests, but licensed clinicians make final decisions. I think that's very important as AI is getting stronger and better. Of course, I think the human brain or someone human functioning could actually look at a person's situation and make sure they're having that final decision. So exclusions, pilot does not affect inpatient, emergency, or other delayed risk services. Okay, that's great because who wants to get a prior authorization when you're in an emergency? Okay, so overarching CMS prior authorization reforms, this is 2026 and beyond, across all Medicare Advantage, Medicaid, which is Medi-Cal in California, ACA qualified plans, including original Medicare with Wiser, CMS is implementing the following CMS wide changes effective January 1st, 2026. Okay, CMS is Center of Medicare Services, so I'm just saying CMS for short. I think this is just a topic that really needs to be brought out, so I'm pretty much excited to give this to you. Maybe I'm talking too fast, so let me slow down. Okay, turnaround timelines 72 hours for expedited urgent request, 7 calendar days for non-urgent request. So my issue with this is I tell my MedSup clients, my Medicare, original Medicare clients, oh, you don't have to get any authorizations or approvals necessary. So really, this is not the case, and what's going to be outlined as something they have to be pre-authorized with those 6 pilot states. So electronic automated process via FHIR API mandates for EPA data exchange denial reasons must be specific. Okay, that's good. Public reporting health plans must publish prior authorization metrics by March 31st, 2026. To me, that's a little bit funny because if it starts on these pilots, January 1st, 2026, that's 3 months that they have time to publish the report. What about the 3 months that lapsed? I don't know, that's healthcare for you. Okay, provider access API by January 1st, 2027, providers must access prior authorization data from payers via FHIR, okay? MIPS/hospital EPA measurements, clinicians and hospitals will report usage of EPA APIs under promoting and operable programs. Okay, so what's the rationale, the goals, and the concerns? Why? Reduce waste and appropriate care by scrutinizing historical overutilized procedures. So I get that. There is a lot of fraud, waste, and abuse going on. We have to certify every single year about that too and report if we ever see things like that. So I get in regards to our gaps and deficit and so forth. I guess I get the reduce waste and inappropriate care. Okay, streamline administrative burden through digital workflows while ensuring patient safety and evidence-based decisions. Okay, cut costs and enhance taxpayer stewardship via CMMI models. Okay, so what are the concerns? Provider burden. Some medical groups worry that even limited PA could increase paperwork. PAs, the prior authorizations, could increase paperwork and delay care in original Medicare. I mean, for those providers, medical groups that don't offer Medicare Advantage or the HMOs or the PPOs and only offer original Medicare, this is going to be quite a shift for them to get those authorizations. Hey, timely access. CMS excludes emergencies, but concerns persist regarding disruptions. Of course, right? Sometimes client thinks it's an emergency, but hey, the hospital doesn't. So things like that, that is concerning. Reliance on AI tools. CMS clarifies that AI assists but does not decide approvals. Okay, yes, AI is still new while, it's moving in a rapid pace. So it's nice that it doesn't decide the approvals. Okay, what this means for beneficiaries and providers. Beneficiaries in pilot states receiving targeted services before January 2026 should prepare for possible delays or prior authorization steps, understand the process for requesting services, regain documentation, and plan to appeal if denied. Providers should become familiar with AI facilitated PA systems, submit complete clinical info to avoid denials, track requirements in pilot states. Nationwide, expect faster authorizations on decisions, transparent denial reasons, greater electronic interoperability. But of course, I mean, with the pilot system and all this, it is going to really take some time to really figure out if this is something that's great, good, or just indifferent, right? Okay, so next steps and monitoring. CMS report pilot outcomes, cost, utilization, quality, patient, provider experience. A CMI expansion could follow if pilot reduces costs without harming quality. Legislative complements. The pending Improving Seniors Timely Access Act would standardize the prior authorizations and expand prior authorization reforms, especially for Medicare Advantage. So really, this could affect Medicare Advantage down the line. Definitely will affect other states, right? Because if it is successful or however it may be, it probably will get to other states. Okay. So, why this matters? So, for the first time, original Medicare incorporates prior authorizations, introducing both efficiency gains and administrative challenges to fee for service care. CMS is balancing cost control with maintaining clinical autonomy and patient access. Pilot results would guide future expansion, meaning all beneficiaries and providers should stay informed, especially in pilot states. And if you'd like, I could explain how this impacts specific services and walk you through state by state provider preparation, or compare this with changes in Medicare Advantage. Just let me know. Okay, so let me, I still have some time. This is definitely a historic shift for original Medicare. Um, as mentioned, this is the first time that traditional Medicare will require prior authorization in non-emergency outpatient care. It has been a long hot button issue in Medicare Advantage, but original Medicare was largely untouched until now because Medicare Advantage, mainly like the HMOs and the PPOs, there are some prior authorizations and approvals needed. So this is quite a different take, especially when it comes to original Medicare. So for decades, fee-for-service Medicare was the no hassle option. What I used to tell my patients or my clients is, hey, no approvals, no authorizations. You could go to any doctor, any specialist, hospital in the nation that accepts Medicare. You just pick up the phone and set up an appointment. But this may not be the case because there are about 17 subjects that are going to need prior authorization starting in 2026. And I get maybe these are the ones that have the highest fraud. Who knows? I mean, I hope they're just targeting the services that have the highest fraud, right? Or they know, because why just burden the consumer or the patient for frivolous things? Okay. So remember that Arizona, New Jersey, Ohio, Oklahoma, Texas, and Washington is the 6 states your doctor may soon need Medicare approval before you get certain back surgeries, injections, or nerve stimulators. So that's the thing, right? I mean, that's the biggest thing. Why choose a Medicare, original Medicare supplemental plan? But now some of these approvals are going to be in place. So, what kind of services are affected? The real world examples I would say is back pain, epidural injections, spinal decompression, so that's big, incontinence devices, nerve stimulators for Parkinson's, epilepsy, tissue grafts for wounds. Okay, these are high cost, high volume procedures where Medicare wants to prevent waste, but delays could frustrate patients, especially if you're just used to not getting any approvals. Okay, so the role of artificial intelligence, but with a human touch, AI will assist with document scanning, flagging, and streamlining, not making the final decision. I hope so. Licensed doctors will still review and decide. And for me, your doctor, your medical group does make a big difference on your advocacy. Of course, you need to advocate for yourself. If you can't advocate, have your broker like us advocate for you, or your family, or your friends. Um, just don't leave it to chance. The government does say AI will speed things up, not take over decisions, but really critics are worrying it could lead to more denials. Okay, timing and urgency. Like I said, it will start January 1st, 2026. So I would prepare now, talk to your doctor, check your treatment plans, and understand appeal rights. Of course, these are for the 6 pilot states, but if you are getting these type of services, I do recommend, even though you're not in the 6 pilot state, to talk to your doctor, see what their take on this and so forth, and just so you kind of have like a head start on thinking ahead and planning ahead. So insightful angles, right? What it means for the rest of our country. CMS has authority to expand pilots nationally successful. This is likely a testing ground for the broader Medicare cost control measures. And really, this might just be the beginning. The pilot cut costs without hurting care. Expect this to expand to all 50 states. Potential patient pushback. We gotta watch for the growing advocacy from patient right groups who fear treatment delays. Medicare Advantage seems high denial rates for similar procedures, and it just, to me, it really depends on the medical group, the doctor, the level of care, even if your location, right? Because sometimes you're in these metropolitan cities, the care, the hospital, the doctors are just top notch versus being in the suburbs or in the rural areas, things like that to consider when looking for where you want your health care, where you want to live in retirement. So some fear this will create Medicare Advantage style headaches, delays, denials, and red tapes. Yeah, it's too soon to say, but if it's going down that way, it is unfortunate. Physician concerns. Many doctors worry about added paperwork, reduced autonomy, and delays in care. Some have already reduced Medicare acceptance due to administrative burden. Doctors say they didn't go to med school to fill out forms, and this can make it worse. Obviously, they should have a staff for that, right? So not sure if they're in the rural areas that they have to fill out their medical forms. Okay, a win for transparency. New rules force Medicare and insurers to publish denial stats, response times, and justification for every denial. So I'd like that transparency, that we could definitely look at that and articulate to the clients what's going on with the particular insurance companies we use. And so the first time Medicare's decision will expose to public sunlight, that's a win for patients, right? So hopefully looking at the positive here. Tying it to the 2024 election fallout and the 2020 politics, I'm not into politics. I'm just talking about fact and just a little bit of perspective as being a healthcare broker. Healthcare reform was a major campaign issue. This could be part of the conversation in midterms and beyond. So will this be seen as cutting waste or cutting care? That just really might depend on how smoothly it's rolled out in 2026. And really, it's based on the individual and your perspective and your care and just your individual needs, right? And your friends and family's individual needs and what you hear out there. So it's just different perspectives on that. So what should you do? Definitely, if you're on Medicare and live in a pilot state, talk to your doctor now. And remember, prior authorizations don't mean denials, but it does mean delays possibility. Okay, we'll be watching closely as Medicare no prior authorization era has officially ended. Well, technically, Jan 1, 2026. But definitely, if you are concerned and you have an individual situation, let us know so we could help guide you through the process. Biggest thing for me is client advocacy. Some seniors, if you can't advocate for yourself or you don't even know and understand the processes of how Medicare or your healthcare works, that's why reach out to us. I've had instances lately where I usually don't have any issues, but I had one recently where a lot of the things the client was saying to me didn't make sense, that they couldn't find a specialist in her area, a particular specialist. And then I said, that doesn't make sense because your doctor, the medical group, should be able to provide you a referral. And if there's no one in their medical group or specialist in their group, like they need to go out elsewhere, right? And give you that authorization. Come to find out, she was actually referred to a top notch specialist. Um, a really top-notch specialist. However, it was really far from her. So she had lived in the suburbs. So she was looking for someone closer. And the person that she was sent to didn't take her medical group. But I mean, that's another issue for another day. But things like that, that's why Premier 360, we do advocate for clients. We do give you options. We think outside of the box. You're just not a number to us. We definitely give you your options, escalate your issues or your problems, give you some sound advice from what we've learned in the past or our experiences, especially in your particular marketplace. So keep that in mind. So yeah, the biggest thing is, for the first time ever, original Medicare, that's the government-free fee-for-service option, will begin requiring authorizations for certain medical services. So that means doctors will need approval before Medicare agrees to pay for specific procedures. Yeah, it's a lot of paperwork. I would say it will take more time to get your approvals, right? So just remember, if you're in Texas, Oklahoma, Ohio, Washington, and New Jersey, we are licensed in those states. Please let us know how we could assist you. If you have any questions, definitely reach out. We have been seeing changes on Medicare supplement, larger increases this year, and it doesn't seem like it's going to stop or decrease anytime soon. So once again, my name is Jennifer Lee, your host at Medicare 360, sponsored by Premier 360. If you have any questions or concerns, please reach out to us. We are more than happy to help you with your situation or any concerns you may have. Thank you, and I will see you next week. Bye-bye.